Today we'll be discussing about oral habits. Habits are a part and parcel of every childhood. Each and every child encounters a particular habit in their lifetime. We'll be discussing about various oral habits such as thumb sucking, mouth breathing, tongue thrusting, and even some self-injurious oral habits. What are the various etiologies of the particular habits and what are the clinical features and the methods of correction or the management of such type of oral habits. So commencing with what is the definition of habit? Habit is nothing but it is particularly a learned pattern of muscular contraction which is compulsive in nature. That means it is basically a group of muscles work in a particular habit. For example, in the case of thumb sucking, the buccinator, the orbicularis oris, and such muscles work together to form that habit. And it is generally a fixed and consistent pattern. Generally, it follows a particular path and it is easy to perform. So there are various classifications which were given forward for the habits, like Moyer's classification of obsessive and non-obsessive type of oral habits. Obsessive means compulsive or which has a particular etiology, like a psychological pattern behind it. That is an obsessive oral habit, like thumb sucking. Then there are certain other self-injurious habits or masochistic habits which have a particular psychological underlying factor beyond it. Then non-obsessive habits. Non-obsessive habits are generally unintentional or empty habits like abnormal pillowing, then chain popping, etc. Then comes functional habits like tongue thirsting due to a particular function, like particular function of the tongue which has the habit of coming between the teeth. So this is the functional habit. There are other classifications which were given forward by various authors like Kingsley and Klein and Graeber gave particular classification. Graeber gave the classification of useful and harmful oral habits. The useful habit is like breastfeeding, then harmful habit is the thumb sucking or the tongue thirsting. Then Kingsley also classified habit as functional, muscular or non-functional. Functional or muscular is basically the tongue thirsting habit. Then comes the compulsive and the non-compulsive habits. The compulsive habit have underlying psychological etiology, whereas the non-compulsive habits do not have a psychological etiology. They may be either primary or secondary, or they may be derived from any other habit. For example, the habit of finger sucking is derived from the habit of the thumb sucking or the tongue thirsting. Similarly, Klein classified habits as the empty or meaningful habits. Then, what is the basic etiology of the habits? There is a trident which belongs to the habit. They can be classified as the intensity, that is how powerfully the habit is followed by the child. Then comes the frequency, that is how frequent. For example, if the child is a thumb sucker, how frequent the habit is there in the child or followed by the child, whether it is a once in a day or twice in a day or 3 times a day or throughout the day. Then the duration, how long the habit is pursued by the particular child. For example, the child sucks thumb for 1 or 2 hours, 3 hours, continuously 8 hours during the sleeping time, etc. Then the direction of the habit, like the direction of the thumb sucking, whether the thumb is placed just behind the incisors or it is placed in deeper sections of the mouth. All these factors determine the after effects or the consequences of the habit. So this was called the Trident of Habit. Then there are certain habits which are nutritional or nutritive habits, or others are non-nutritive habits. Under the nutritive habit comes the breastfeeding, or the rooting reflex is the main reflex which underlies this habit. That is, now what is rooting reflex? Rooting reflex is a movement of the mouth of a child towards any object which touches the cheek or is around the mouth of the child. This is the rooting reflex. And the basic habit of suckling depends on the rooting habit. Now, what is suckling? Suckling is intake of fluids by placement of the tongue between the lips and maintaining the lip seal. This is known as suckling. So this is the nutritive habit because the infant derives the nutrition by the means of this suckling habit and the rooting reflex. But if there is prolonged breastfeeding or this type of habit is continued beyond 3 years of age, 2 to 3 years of age, then it may lead to certain deleterious effects on the occlusion or may lead to proclination of the teeth, then prognathic maxilla, etc. Then comes the non-nutritive habit. The main non-nutritive habit is the thumb sucking. Now, what is thumb sucking? Thumb sucking is basically the positioning of the thumb in the mouth or the oral cavity of the child or by the child at various steps inside the mouth. It may either be just a part or the tip of the thumb in the mouth, or even half of the thumb touching the palate, or the full of the thumb inside the mouth of the child. So there are various steps on according to which the thumb is kept in the mouth, and this further will affect the severity of the malocclusion encountered by the means of thumb sucking. So what is the thumb classification? Now, it can be classified as either normal or abnormal. Normal thumb sucking comes under 2 years of age. For example, as the infant is in the womb, it has the habit of placing the thumb into the mouth. So this habit is carried from the womb of the mother. When the child is born, similarly, the child enters the oral stage according to the psychological stages which was given by Sigmund Freud. So the child tries to keep their thumb into the mouth. So if the habit is continued beyond the age of 3 years, it is called as abnormal oral habit or retained digit sucking. Now, what is the underlying etiology, or why does this habit is retained by the child? Why it is not discontinued, or why it is continued by few children and why it is carried over along the years by few other children? The basic cause of thumb sucking is generally an underlying psychological cause. For example, if the child wants some emotional or psychological security, the child generally resorts to this thumb sucking habit. So, first is the factor of the psychological security which the child strives to secure by placing the thumb into the mouth. Second is if the child wants nearness of the mother or consolement for the mother and the mother is not around the child, again the child resorts to this activity of thumb sucking. Now, if the child has issues with the social structure around, or the child feels insecure in the company of other people, then again the child will resort to this habit of thumb sucking. So, there was another theory which was given, which is known as the oral drive theory, which was given by Sears, is that if during the oral stage of life, if the gratification by suckling is not provided to the child or the security by the mother is not provided to the child will continue this habit of thumb sucking. So, in order to retain again the emotional stability and psychological gratification of the hunger urge by the child. So, if the child is not given proper feeding, then the child will resort to thumb sucking. Even in some cases, there is the opposite. If there is excessive feeding of the child, this will also lead to continuation of the habit of thumb sucking. This is because the mouth is an erogenous zone according to the oral drive theory or the oral stage of psychological development, and the child tries to gratify itself by the means of thumb sucking through mouth. Now, if there's a persistence of habit beyond 3 years of age, then this will lead to deleterious consequences, or it will lead to malocclusion. It will lead to change in the orofacial structures, the jaws, the teeth, even the extraoral structures like the thumb will also be affected. So, if we examine a child of a thumb sucking, or if we examine a thumb sucker, we can easily identify that the child is a thumb sucker since a long time. So first we'll see that how is the thumb of the child. The digit or the thumb will be generally clean. It will be very clean, and the fingernail will be cleanly trimmed, and the tongue will be somewhat, we feel the thumb is compressed, or it is dish pan shape. Sometimes also we can find a callus formation in the frontal segment of the thumb. So we can identify easily whether the child is a thumb sucker by the means of examining the thumb of the child. Second, we come to examine the lip of the child. Generally, the upper lip is everted upwards and the lower lip is hypertrophic and it is hanging downwards, and the lips are generally apart, and the child may also be a mouth breather due to the thumb sucking habit and the open bite which is led to as a consequence of thumb sucking. Now, how is the facial profile of the child? There will be a maxillary protrusion, a mandibular intrusion, open bite, or the teeth will not fall in part together. There will be decreased overjet and decreased overbite. The profile of the child will be convex, and there will be hyperactivity of the mentalis muscle, and we also call it as a puckered chin. Small projections are present. Depression, the projections will be present on the chin of the child who is a thumb sucker, or such a child has a hyperactive mentalis. Then intraoral examination of the tongue reveals the tongue is sometimes very clean and it is at rest and it is at present at a lower level. The gingiva will be generally hypertrophic and sometimes hyperkeratinized due to mouth breathing. Even the margins of the gingiva may show signs of marginal gingivitis, and they may show reddening, and bleeding on probing may be present sometimes. Then other dentoalveolar features are like flayed or proclined maxillary incisors. There will be spacing present between the incisors and the teeth. There will be anterior open bite. The arch of the child will be collapsed sometimes, and there will be narrowing of the maxillary arch, and there will be a deep fault of the maxillary arch which is found in such cases because of the thumb is placed in continuous contact with the heart and the soft palate. Sometimes due to this narrow maxillary wall, there will be cross bite, which is generally lateral or posterior cross bite. Sometimes the flaring of the incisors, the excess proclination of the incisors, the open bite, the increased intermolar distance, and the more distalization of point B, which is the point present just below the lip, will be there. And sometimes the mandibular anterior crowding is also present. Now, we can see generally in such cases of thumb sucking, the child has a class 2 malocclusion if the child is a thumb sucker since a long duration of time. The overbite will be decreased because of the open bite. In such cases, there will be a posterior cross bite. So these were the dental, the extraoral and the intraoral features in the child who is a thumb sucker. The various psychological underlines of such child is basically an introvert. He will not interact much with the people around. He will be very depressed and dull and show immature social behavior. Generally, the child will be standing out in crowd. He will not mingle with the crowd and also has difficulty in speech because of the open bite, because the tongue will try to come in between the teeth and will hamper the speech of the child. The child will also be very sensitive to small issues and will keep on crying very easily. So What is the treatment of the thumb sucking habit? First of all, there is a psychological treatment. We'll find if the case or if the child is having any psychological underlying cause, or there's separation anxiety from the mother, or whether it's excessive of feeding or decreased amount of feeding during the infant age, or the child is very introvert, will not try to mingle with other people around. So we'll find out the psychological cause, why is the thumb sucking habit retained, or if some other sibling around is also taking the thumb and the child has grasped the habit from the sibling who is present. The first step of the treatment is always preventive. So we'll try to see how we can prevent the habit. This can be done by various measures like extra long sleeve. If the night suit, child wears a night suit, then we can place a extra long sleeve in the night suit, or we can pin the sleeve, or we can put a dummy or a pacifier in the thumb of the child. We can also put a bandage in the thumb of the child, or sometimes we can also use a long bandage and tie it around the hand of the child so that the child does not move the thumb towards the oral cavity. There's another hypothesis which was given by beta hypothesis, and it states that if we forcefully ask the child to suck their thumb and sit in front of the mirror, the child will discontinue the habit in after a few proceedings of the same procedure. Then there's another least effective way by placing of chemicals like femite, etc., or black pepper spray on the thumb of the child so that the child will find it distasteful to suck the thumb. There's another extraoral approach like tying, as I have already told, adhesive bandages and the cloth around the thumb of the child. There are mechanotherapy for correcting or discontinuation of the habit of the thumb sucking by the means of removable and fixed appliances. So like the removable appliances are like hair rakes or oral screen, and the vestibular screen. The quad helix also helps in expansion of the arch. Then a bluegrass appliance, which was also given by Haskell. This appliance has a particular ball which is present in the rugae area, which is attached to the wires, and the child gets engaged into the activity of playing with the ball rather than the initial activity of thumb sucking. So this is how the habit can be discontinued in the child. So if the child is less than 3 years, then we can ignore this habit because it may due to the oral urge. So after, if the child is from 3 to 7 years, then we have to go for behavior modification technique, uses of bandages and sprays in the child's thumb. If the child is greater than 6 years, we will go for behavior conditioning, the psychological counseling of the child, and again the use of habit breaking appliances like reminder therapy, like the hair rakes, the oral screen, or the unpleasant stimuli, the bandage around the thumb, etc., and the reward system. If the child discontinues the habit for the such time, we can reinforce the positive discontinuation of thumb sucking by rewarding the child with certain good objects or gifts. So appliance therapy, as I have already told, is a fixed appliance therapy which consists of the quad helix. There are various 4 types of helix which helps in expansion of the arch, which is narrowed by the means of thumb sucking, and the palatal crib will prevent from placing the thumb in the child's mouth. So this was the entire etiology, the clinical features, and the treatment and the management of the thumb sucking habit in the child. Now we come to tongue thrusting. So tongue thrusting is nothing but it is the placement of the tongue between the lips and the anterior teeth of the child. It is a forward placement of the tongue. It will be present in the newborn and will be omitted by the age of 5 to 6 years and be continuously discontinued by the age of 30. So there are various types of tongue thirsting, that is the non-deforming anterior tongue thrust, the deforming posterior tongue thrust or the lateral tongue thrust, then the deforming anterior and the lateral tongue thrust, which can be divided into further groups like posterior cross bite, the anterior open bite, etc. Now, what is the basic etiology of the tongue thirsting? The basic etiology is the retained infantile swallow or the retained suckling urge. As I have already told, suckling is the placement of the tongue between the teeth. So, if this swallow pattern is retained, the child will be followed the habit of tongue thirsting. It may be either due to enlarged adenoids which are present in the tonsillar area, or the enlarged lymphoidal tissue or the hypertrophic lymphoidal tissue, which will lead to forward placement of the tongue and forcing of the tongue between the teeth. They may be also be due to the neurological disturbances like hyposensitive palate, etc. The functional disabilities, for example, anterior open bite, will help in forcing the tongue between the teeth. Or if the child is having a thumb sucking habit, then also the child may encounter with the tongue thirsting habit if there is increased overjet, decreased overbite, or protrusion of the teeth. This will lead to a tongue thirsting habit. If there is prolonged breast or bottle sucking by the child, then also the child will retain the habit of suckling and will fall into the trap of the tongue thirsting habit. There are certain other habits which induce tongue thirsting like finger or digit sucking, then thumb sucking, then pacifier habits or abnormal sleeping habits. It may also be due to the underlying hereditary cause. For example, if some other sibling is thirsting the tongue, the child will catch it from the other sibling. If the size of the thumb or the tongue is very large, or in the case of macroglossia, the tongue will be forced in between the teeth and will follow the habit of tongue thirsting. For example, if there is any trauma or abnormal deglutition to the entire swallowing mechanism, then also the child can have the tongue thirsting habit, or defective speech will be followed later on. So, on examining the tongue may have lateral indentations, may be hypertrophic, may be excessively big. There will be macroglossia in the tongue, and anterior, forward, lateral movement of the tongue will be possible. The other clinical features will be the extraoral features like the lip posture, the lip or the lower lip will be hypertrophic, or there will be separation between the lip. The mandibular will be moved forward and downwards in the case of tongue thirsting. There will be speech disorders and pronunciation of certain consonants like S, V, F, D will be improper. There will be increase in the facial height or the facial angle. The intraoral features or the features of the tongue will be downwards and forwardly placed. Even the maxilla will have the open bite, or there may be separation between the teeth, spacing between the teeth, flaring of the teeth. The posterior crossbite will be present, or the lateral crossbite will be present. Sometimes the anterior crossbite is also present, and there will be intermaxillary discrepancy. Now, what is the treatment of the tongue thirsting habit? First, it depends on the age. The correction of the suckling habit should be done. The psychological counseling should be done. If there is an underlying thumb sucking habit, it should be corrected. Then any other malocclusion due to which the thumb sucking or the tongue thirsting has arose. For example, if there is increased overjet or the overbite or open bite, it should be corrected for correcting the tongue thirsting in between. If there is a speech defect, the speech defect should also be corrected, and other associated habits should be corrected. Now, what is the basic mechanotherapy and any other appliance therapy like hair rakes, and the various exercises are there, which are the myofunctional exercises, which is called spot, salivate, squeeze and swallow. That is, we spot a particular point on the rugae area by the means of tongue just behind the incisor teeth. Then we squeeze the tongue, then we salivate, and then we swallow. This is the exercise which is taught to the children who are encountering the tongue thirsting habit. Then we also teach the children to whistle or reciting 40 to 50, then yawning badly. 2S and 4S exercises are there, and holding the button between the two lips, then pushing the lower lip above the upper lip, and other subconscious therapy of preventing the thumb or the tongue from thirsting in between. Then speech therapy is given to the children who have a defective speech for the correct posture of the tongue into the mouth. It is generally not indicated less than 8 years. Then the pre-orthodontic trainer or myofunctional appliances can be given which prevent the tongue from coming in between the teeth. The tongue guards, the mouth guards, the rakes, hair rakes, or the Holly's appliance modification by the means of an active labial blower and addition tongue crib can be applied to the Holly's appliance to prevent the tongue from thirsting in between. Oral or vestibular screen is another option. We can, if there is an underlying ENT cause, then we can go for removal of the adenoids or the tonsils or the hypertrophic oral or mucosa also. So these were the underlying causes of the tongue thirsting and their treatment. Now comes another very important habit which is known as the mouth breathing. Mouth breathing is the habitual breathing through mouth instead of nose. There is various classification. It is anatomical, whether it is due to obstruction or whether it is habitual. The etiology lying is due to asymmetry of the face, or there is asymmetry of the nares, or due to deflected nasal mucosa, abnormal nasal cavity, short upper lip, and maybe due to underdeveloped nasal turbinates. Then, if there is an obstructive etiology, there will be deviated nasal septum, or there will be lowered nares, leontiasis ossea, or the narrow maxilla. There can also be traumatic injuries to the nasal cavity. There can also be inflammation in the nasal mucosa or a genetic underlying factor. The clinical features of the mouth breathing are generally the extraoral features will be the pulmonary features, like there will be pigeon chest and the child has very narrow face, and esophagus will be generally dry, less than 20% of saturation of the carbon dioxide. The dental effects will be the increase of the overjet, the increase of the overbite, the open bite, lower tongue posture, and the posterior cross bite. Generally, the faces of such children are long and narrow, which are also known as adenoid faces, which have long, narrow, slit-like nares, depressed nasal ridge, depressed cheekbones or the maxilla, and a very expressionless face. So, there will be also increased overjet or overbite, constricted maxilla, and due to constricted maxilla, there will be the probability of the cross bite. The palatal vault will be narrow and long, and the child will have a long, narrow face. The lips will be, upper lip will be hypertrophic and lower lip will be hypertrophic and voluminous and will hang out, and the external nares will be slit-like. Sometimes in the case of mouth breathing, the gingiva is dry and it will be hypertrophic. And the diagnosis of the mouth breathing can be done by the means of the water holding test and the butterfly test and other test. And the water holding test, in this the child is asked to keep the water in the mouth for some time. If the child is a mouth breather, the child will not be able to keep the water in the mouth for a minute because the child will breathe through the mouth. Then the double mirror test is placing two mirrors between the nares and the lips of the child. If there will be fogging of mirror on both the sides, that means the child is both the nasal and the oral breather. Then other tests like butterfly test by the means of cotton and indectic crystallography is also done. The treatment of the mouth breathing is by the means of oral screen generally, which is a mechanotherapy, and preventing the child from taking the air through the mouth. if there is an underlying ENT etiology, then surgical correction of the nose like deviated nails, septum, or highly placed nails, etc. should be done. The child should also be asked to play the windpipe or hold the disc in between the mouth. Some other mechanotherapy exercises were there, and other maxillomechanotherapy appliances like the oral shield or the oral screen and the Mackey's activator can be given to the child for the correction of the habit. If the child is having a class 2 malocclusion, then there are various appliances which are given to correct the occlusion, or the oral screen is also given. Then there are certain habits such as lip habits, that is placement or directly wetting of the lip into the mouth. This is a continuous habit. It may lead to reddening of the vermilion border of the lower lip, and it may lead to cracking of the lips also. The lips may become hypertrophic and may hang out of the mouth. The lips may be apart when will not be competent. The underlying etiology may be due to some anxiety factors, class 2 division 1 malocclusion, increased emotional stress. The lip will be red, the vermilion border will be irritated, sometimes the margins of the lip will be chapped and irregular, and there may be also the probability of herpetic infection in the lips. Now, the lip habit can be prevented by placing an oral screen or the lip bumper or the plumper, and preventing of the patient from biting the lip. Then it can also lead to retrusion of the lower incisors, the protrusion of the upper incisors, increased overjab, decreased overbite, and even open bite. So, as I've already told, the oral shield or the lip plumper can be used in the treatment of the lip sucking habit. Then comes the bruxism. Now, what is bruxism? Bruxism is nothing but it is grinding of the teeth. It can be either due to stress, which is known as ochinuria, then diurnal bruxism, which is present between the day, and the night time, or the nocturnal bruxism, which is present in the night when the child is sleeping. The main etiological factor of bruxism is the presence of stress or anxiety in the mind of the child. Now, what are the clinical features? The occlusal surface of the teeth will be entirely attrided or flat, and there will be shining facets present on the occlusal surface of the teeth. Sometimes if the dentine is exposed, it may lead to sensitivity of the teeth, and even pulpal exposure will be there, so it may lead to the management by root canal treatment and the crown placement. Now, what is the management of bruxism? We can give a night guard or the acrylic plate to prevent the teeth from grinding together, and this is a preventive therapy. Then the treatment can be root canal treatment or use of desensitizing agent if the dentine or the pulp is exposed. Then if there is a problem in the TMJ or the pain in the TMJ, then we use a prefabricated intraoral appliances for the TMJ disorder. Further pulp therapy or stainless steel crowns, tension relief can be given to the patient for the treatment of bruxism. Then comes a cheek biting habit. It is the placing of the cheek between the teeth. The clinical features will lead to whitish discoloration of the teeth, ulceration of the teeth, even hyperkeratinized cheek mucosa. The main treatment for the cheek biting habit is vestibular screen or the reminders. Then comes the nail biting habit. The habitual taking of the nails, and generally done by the children. The nails will be chapped or cracked, and there will be irregularities in the skin surrounding the nails. This will be due to underlying emotional or psychological problems. The dental effect will lead to crowding of the teeth, sometimes notching of the incisors, and attrusion of the incisors will be present. So this can also be prevented by placing a solution or the nail polish or some covering the nails of the child, and psychological therapy to the child. Now, last but not the least, comes the masochistic habit, which are self-injurious habit like freedom thirsting or chain popping, tin popping. Then it can also be placing of bobby pins between the teeth. This will lead to indentations on the teeth and will lead to deleterious oral effects. So this can be corrected by another psychological therapy. It can be either organic. Leach-Nyhan syndrome is a syndrome which is associated with the self-injurious habits, and they can be repetitive. Sometimes it can be combined also, like the finger, the thumb, the cheek biting and the nail biting together, it all come. So these are all the self-deleterious habits. The management can be done by psychological counseling or referring to the psychiatrist, and adjunctive therapy or the mechanotherapy, like placing the rakes in the mouth or the oral screen or the shield or the lip bumper, can prevent such habits. So oral habits are a very important or effluent part of the psychological effect of the child, and they can be corrected and prevented by various means. Thank you.